Dr. Bancha from Thammasat University, Thailand. Thank you for the invitations. I never missed the class meeting. Never. No, only one in Vietnam. Sorry, only
knee
one.
also.
Oh yeah, I'm knee and shoulder. In the morning I'm knee. Now in the afternoon I switch to be shoulder. So the posterior instability. So first thanks to the CONMED, Vivatech, and also the host for organizing this wonderful meetings, and also thanks for the warm welcome yesterday. Posterior instability is about 2 to 4% in all instabilities. That's classified into two groups: the traumatics and atraumatics. Okay, atraumatic is like seizure, electric shock. Sometimes we miss that, and sometimes they just a label tear. Okay, and in atraumatic we classify into two groups. The patient have repetitive injury, okay, like sports, or the patient with MDI, the bone loose. So the major direction most of the time is the posterior instability, like this girl. She has an involuntary posterior instability. Okay. So I show you the first. This is a traumatic tear. So sometimes the patient can fail on the elbow, like dashboard injury, and we miss that. Often miss that because it's not obvious, like anterior instability. Okay, patient can come to see you with the shoulder pain, just elevate. It's so much pain. So this kind of patient will not come to see you with the instability symptoms. They come to see you with pain. Okay, so this patient have chronic pain, and sometimes if you do just the MRI, you cannot see. You need MR arthrogram to see the label pathology. Okay, so this is another examples of the traumatic posterior dislocation. Okay, sometimes the general orthopedic can miss that. Okay, but we are the shoulder guys. We never miss this condition, the lock dislocations. So the repetitive injury, like the occult instability, patient may come like ligament subluxation, not obvious dislocation. They may have like a slap lesion combined with the posterior labral tear. Sometimes they may have like the occult labral crack or Kim's lesion. Okay, this is a repetitive injury. Show you one example. Okay, this guy is a blacksmith. They doing this way every day, thousands a day. So that's axial loading to the posterior labrum. So the label crack and torn like this. Okay, so sometimes we miss that because we not thinking about that. Okay, so another situation is the bone loose, the patient with a multiple MDI. So this kind of patient most of is female. Okay, may have the mid-length instability and dislocation from minor trauma. Okay, so you can see that this kind of patient most of the time they suffering from the posterior shoulder pain or instability and loose joint. So this group you can classify into three groups. Okay, the voluntary or involuntary. The voluntary you can classify into positional. So patient need to do adduction, internal rotation to dislocate the joint. Or this is the muscular dislocator. They just contract the muscles. Okay, can have this dislocation, but careful, this condition should not touch it, and these conditions. Okay, this is an involuntary dislocation. Patient cannot control. Okay, many times they have the scapular problem. So first you need to classify the examination, laxity test or instability test. We need to classify. The laxity test show the loosening, okay, but instability test produce pain. So it's not the same. So like, and examples, you need to check also the scapular bone. Sometimes they combine with the wing scapula. Sometimes patient may have cervical spine or brachial plexus injury can cause laxity of the joint. Okay, and very important, you let the patient show you how can you do that. So this is positional, this is involuntary, this is a muscular dislocator. Okay, like this patient, this is an involuntary dislocation. Okay, most of the time they have pain when they elevate and they have subluxation of the shoulder. Okay, this is a voluntary positional, and Brighton score we always test to prove that they have the general laxity or not. Laxity test did not produce pain like drawer, Sauka sign. Okay, this is a laxity test. Okay, painful hyperabduction. This is another situation that you need to concern. If the patient have so much pain, if they do hyperabduction, thinking about the instability also. Okay, and also jerk test. If jerk has no pain, that is just like laxity test. But when it produce pain, thinking about the instability or labral crack or labral tear. Okay, that's my observation. Posterior apprehension test. Okay, produce pain also. Okay, and also the posterior inferior label shift test is a Kim test. Also, sometimes the O'Brien test can produce pain. This patient is professional goalkeeper. They also have the label tear in the back. When you do O'Brien, okay, this produce pain because you have axial loading to the back of the joint. Okay, so many times. So examination intra-op quite important. You need to check again. Okay, because if there's instability, I will put the patient in different position. Don't forget to check the scapula. And many times, this from the literature, patient with scapulothoracic problem, many times they have 2 times list of the shoulder instability. Okay, this patient we treat conservative by stabilize the scapula. You see, after we press the scapula, the shoulder stable. So this small little lady, we treat her conservatively by train her periscapular muscles, train her scapular retraction, and she's getting better from the conservative treatment. Okay, we start from the conservative treatment first, always. This patient, we conserve her for 6 months, you see. After she go to fitness first, she getting better. The shoulder getting more stable. Okay, indication for surgery is to fail conservative for at least 6 months, involuntary instability and persistent painful jerk. Okay, our goal is to restore the shoulder stability. This is my position. I put patient in supine, traction on the same side, not lateral decubitus. Okay, always check the patient stability every time before surgery. Okay. And we did the triple instability portal, only 3 portals. Our first portal is posterolateral, one just beneath AC joint, one above the subscap. I showed you the case scenarios. This is a man. He used to be a b-boy, dancer. He has shoulder pain, okay, and there's a painful jerk. So we found that he has torn posterior labrum. So intra-op, we found that the patient have loose, and yeah, this is his shoulder. There's some cartilage problem also because of the repetitive injury. So we did the So after the surgery, the patient getting better. Okay, now he's feeling much better. The pain. This patient come with a different situation. He come with weakness of the right shoulder. Many times the posterior labral have the cyst because of the leakage, like Baker cyst of the knee joint. That's like one-way valve. So this patient came with the weakness and pain. This patient also have no history of trauma, but he came with shoulder pain. O'Brien test positive, okay, and so this is shoulder examinations, okay. So we get in and we found that the patient have the, we take 3 portals all the time. Okay, the cardiac is not so good now because of the repetitive injury. So we detach everything and then we repair the labral back. Okay, same like. Okay, and he's getting better. So this is my medical student. He play badminton, but he pain when he do backhand this way. But forehand, no problem. So backhand, so much pain. So he came to see me with, oh, I have shoulder pain. Have no problem about the instability. My problem is pain when I do backhand. So that's the examination intra. Okay. So when we get in, we found that he has a labral tear, extend to the slab. So we detach the labrum and finally we fix the labrum back and also repair the slab. Okay, that way. Okay, he's happy and can back to play again. Okay, this is very important. She is seizure, electric shock, and she has done 5 times operations, still have pain, and this is position that she produced pain. So this referred to me because of the rehab. But her shoulder get arthritic change now because of the 5 operations. Okay, so we get in, we detach the labrum and fix the label back. Now she's happy. Another patient, this is 3-time operation from one hospital. She had entry dislocation, but after the operation, there's some arthritic change because of the open surgery. Okay, she got the capsulometaphy arthropathy and has posterior instability. But first time she has anterior dislocation. But after stabilize the anterior, she got posterior instability. So this patient we get in, we detach everything and refix it back again. Okay, that way. Okay, but very sorry, her shoulder get arthritic change. She's still very young. Okay, the last patient lock dislocation. We fix everything, repair the labrum, also make a anterior McLaughlin, repair the subscap back. So after surgery, we also can reduce, even it's lock dislocation. Okay. So in conclusions, yeah, instability we classify in 2 groups, atraumatic and traumatic. You need to concern, don't forget the periscapular muscles like scapula and also the MDI in the traumatic group. Okay, if there's problem, you do capsulolabral repair. But in traumatic group, okay, most of the time we need surgery, posterior labral repair plus McLaughlin procedures. Thank you.
Thank you, Bancha.